So what I've been asked to do is to talk a little bit about the baseline study. I'll tell you the baseline study is still being designed. So the other ask was to think a little bit about what's going on in the technology space. And it may or may not be relevant to the discussion for the design this year, but it's worth just thinking, where is tech and healthcare colliding, and does any of this resonate where SHAPE is going to be going, maybe not today, but 5 years, 10 years, 20 years down the road. At a very high level, I was talking to someone at lunch to ask, well, what is Google Life Science? And so Google Life Science grew out of Google X, so we know there's parent Google, and that's where things like Google Search live. Google X is the research and development arm, and people are familiar potentially with the driverless car, or Project Moon, where balloons are in the sky trying to deliver the internet. And life science was incubated there as well. And the concept was trying to think about ways to have technologies that will help us be much more proactive as opposed to reactive with our healthcare system. So we know a lot of care right now is episodic, so you come and see your doctor, you get a coronary calcium score, you get a lipid monitor. But what would happen if we start to shift some of the healthcare that we provide outside the four walls of a clinic and really bring it into the sphere of the individual participant? And so even though you'll hear there are a number of different projects going on, I would say this is one unifying theme. And much of what I talk about today is not meant to be, it's not an infomercial about what's going on in Google Life Science. It's generally where a lot of the tech space is moving in this way. So I want to make sure that's clear as well. When we think about why would tech groups get interested in life science, well, the first thing is obviously a major contributor to something that affects all of us, so it's a big problem. And the other thing is, you think about the concept around a lot of the original tech companies, and particularly the internet, their mission statements are to organize the world's information. And if we just think about healthcare and the extraction of information, whether it's a patient's story or whether we get information from a coronary calcium score, we're really, in some ways, extracting information, developing models of disease, thinking about better interventions, and more we know we're going to be judged by outcomes, right? So the fee-for-service model is no longer going to be our model, regardless of whether you're a pharmaceutical company, you're a healthcare provider, you're a hospital system, we're going to be measured on outcomes. And so we need to do the best we can to organize information. And I think that's where some of the tech space will be partnering very closely with the academic space to try to make sure we're doing the right thing. In terms of the approach, specifically at life science, we're zooming in on health and disease and space and time. We have some initiatives that are on the population level, and we're going all the way down to the molecular level and trying to do complex systems biology. Again, the thought is that there's a lot of data coming out of this, and what uniquely can be done in places that have very large data centers is try to sort through this data. Then specifically, and this is where, as we think about SHAPE and we think about different studies, how is this new research paradigm unfolding? And so we know that there are a number of medical devices, and I'll talk briefly on those. There's this tech translation, there's clinical and life science in this space, there's academic partners, pharmaceutical partners, and all of this is feeding back to a better understanding of the population, but also the individual. And I used to think it was very hard to reconcile population health and specific personalized medicine, but the more I understand how data can be captured in this way, both about an individual, but also about a society, and even about the environment that someone's living in at a very high level, so pollution data, for example, I believe we are going to get to this perspective where we understand both the overall population and the individual. Specifically thinking about devices, so if you think about coronary calcium as one way of getting, it's a technology, as Sanjay said, and I think the hope is to have these technologies so that doctors have more time to spend with their patients. So I will put a plug in for that. But we're going to have to learn how to use these technologies. Originally, they may be a bit of a burden. You're getting someone's blood pressure 24 hours a day. What are you going to do with that? It's going to keep you up all night, and see, look at his head. But if we can build algorithms that help support the physicians, that's the goal. So we have more time to truly be doctors. So what is going on with technology, and what I've been most blown away by, if I use those words, is really the miniaturization, right? So, I think about something that's big and clunky that you have to wear around. So I think people sometimes talk about the Holter monitors with all the different cords, but there's a huge push to try to miniaturize different technologies, and this is one example that is now a public example, and it's a smart contact lens. And within this contact lens, there is essentially compute power. And in fact, there's more abilities that I've been told just on this chip than there were on the Commodore 64, which was the first computer I had. I'm sure everyone had their first computer of choice, but my family loved it. And I remember we played very rudimentary video games on it. But the idea that this miniaturization is going on, and also the power supply is all embedded in there, is quite dramatic. And what the idea is to try to measure glucose in the tears so that diabetics no longer have to stick their finger. And then if you close your eyes, there will actually be light sensors, and it will go, for example, red if your levels are too high and green if your levels are normal. So, so this is the wave. This is where people are thinking. Now, I said, why are people thinking about this? Well, managing diabetes currently can be a fairly invasive and intensive monitoring system. The second thing that's come up today is talking about behavior change. So the adherence rates of 55%, it made me think, gosh, shape is truly agnostic, right, and has no angle. I mean, should really the tackling factor be behavior change?
Except for Mac without.
Right, okay. Individuals aside, and it's not to say one thing or another, but it's really our biggest hurdle, our biggest challenge is going to be behavior change. And one interesting thing about thinking about making monitoring less cumbersome is, I don't know if someone's not a type 1 patient, would they be monitoring and changing their drugs based on data? Probably not. But you may change your behavior, right? If you have a donut and then your contact lens is starting to blink red all the time, you may decide not to do that anymore. And so these are things to think about. I mean, how are we actually changing people's lives and trying to be more proactive? And then this circles in really on what are the chip requirements. And these, I mentioned, they're getting smaller and smaller. There's wireless power. And this is just really to point out that one of the people who works on these projects is really trying to get the chip so small that it could be in a red blood cell. I'll come back when we get to that. But that's where people are going. Then there's this other idea of trying to capture people in their free living environment. So what does it mean when you see someone in the hospital space? Well, you're not actually seeing what they're doing in real life. And so there are different cardiac monitors. There's some that people probably have on today, kind of the Fitbit varieties. There's a push, however, to go to the other end of the spectrum and make sure that we have medical grade devices so that we can extract information. Again, we have to think how relevant this is, for example, with the SHAPE mission, but many people are thinking about trying to tailor clinical studies so that we get the best physiologic data. In fact, it may help us substratify. We talked earlier about heterogeneity in atherosclerosis. There's likely heterogeneity in a lot of things that we see and we call one disease state. And as we find and track people in their environment, I have a feeling we're going to do a better job with phenotypes. And then, so if you think about it, so we have miniaturization of technology, we have wearable devices. The next generation of tech is trying to just make this almost passive so that you have sensing that has almost nothing to do with you wouldn't even know that it was being sensed. And so this is one device, a LiftWear device. It actually has an interesting story. It came out of it was a device trying to stabilize snipers. So when someone was going to shoot, they realized that they could pivot and try to make this a type of device that's actually very helpful for people with tremor. And so it cancels, if someone has a Parkinsonian tremor or essential tremor, it cancels the tremor. And so that's one thing that's nice. But from a study perspective, if we start to think about ways of integrating non-invasive sensors, so is it something in the cardiovascular space, are we looking at stress reduction or things like that, and we're measuring what people are experiencing, we're going to have a much better understanding of ways to tailor therapy. And then getting really small, so now I went from sensors, non-invasive sensors, and then there's nanotechnology where actually you have, as it's been described, a leg press, or mini robots going through your body, sampling. Could they actually go and look at your coronary calcium on a daily basis? And again, this is far down the road, but this is another area. And then as we think about partnerships between the tech world and traditional research paradigms, I think understanding how to tap into some of the data centers becomes very important. Because in studies like the ones that Samir was talking about and ones that we're contemplating, you can get up to 4 to 6 terabytes of data per patient per experience. And so if we think about how to store that, process it, understand that information, we're going to have to be creative with data centers and ways to interact with them. And one nice thing, at least in some of the big companies where you know that the internet can't go down, there's about twofold as much storage space, so you can kind of tap into that in its downtime. So in the last few minutes, just talking about the baseline study, I'll say it's a work in progress. So you won't see a lot of granularity, but I'll share with you some of the high-level vision, and we're certainly open to input. The hope is that this study is going to be additive and complementary to all the studies that you've heard, complementary to Framingham, the Million Veterans Project, A Healthy Heart, to some of the work that Samir and Al-Fuster are doing with children, for example. So again, the spirit is that this should be additive to what is going on out there. The baseline study currently has a pilot stage, so what the aim is to take patients who are healthy and define what does it mean at a deep molecular level to be healthy, because a lot of studies end up focusing on the patient or participant once they already develop or manifest a disease state. I think we were talking about that earlier with coronary calcium. You're catching someone when they have a certain disease, but what does it truly mean if you look, for example, at phased whole genome sequencing, RNA-seq, the inflammasome, and link all of these? So it's really a complicated human systems biology question, but without knowing the baseline as a reference point, we won't know if we detect a very interesting signal in cohorts with disease, whether that's a real signal or not. So this is currently in the pilot stage. In terms of the vision for the larger baseline study, and the reason why the pilot study is so important is around feasibility and sample acquisition, especially as we're trying new molecular phenotypes. The goal going forward is to try to characterize human systems biology in health. So I mentioned this concept of health, but then the transition to disease. And I think the question comes up, why are we waiting until someone has a mass? So why do we need to detect breast cancer via mammography, for example, or even MRI? There likely are circulating tumor cells that could be detected, for example. So trying to capture this transition to disease so that we can detect, act, and prevent disease quicker. The second one is coming up with these novel markers that I talked about. And again, it's a little bit different than the concept. Certainly the biomarker world has been quite filled with lots of different studies, but we're trying to capture this transition between health and disease, and then focusing particularly on cardiovascular and cancer. And then the final one is establishing a framework to try to streamline studies. And I did like some of the study designs we heard today where we're trying to be clever, facile, because the era of having very large cardiovascular trials, while I am a clinical trialist, I believe in randomization, you'll see that in a minute, we need to figure out ways to be more efficient. And so if we tapped into some of the interfaces where we empower participants to provide data, for example, we have more streamlined inclusion and exclusion, we're probably going to be doing a service. So this, the study, what I will point out is there's going to be clinical and molecular inputs, sensor inputs, patients are going to be interacting with the portal. And then the last piece I do want to highlight is how are we going to integrate all of this data. And I don't know ultimately in shape whether the amount of data will be something where these kind of large platforms need to be considered, but what I've been humbled by is to think about the platform before we start getting the data, because what one doesn't want to do, especially if sensors are built in that really require a lot of data extraction, you don't want to start something and then have the whole system shut down, or even worse, collect the data and not be able to analyze it. And there's a huge push to try to figure out how to merge all of these different data types, come up with an analytic platform that one day will actually be able to be publicly accessible. And so it's been incredibly fun to think about ways to actually make this work. We hear this era, and I'm almost loath to say it, this big data era, what are we doing with big data? But unless we're able to put it all together and come up with meaningful signals, I think we're going to be a little bit stuck. And so there's a huge push to understand how to integrate the data, process it, and then at the back end use, for example, machine learning algorithms, thinking about data and signals a little bit differently than I think we have traditionally in the biostatistics field. And so working with groups that have been applying these algorithms for a long time. So for example, the machine learning groups spent a lot of time with YouTube videos, and they go and try to find similarities in all the patterns. And if we can overlay some of those analytics to the healthcare space, hopefully we will make new progress. And then my last point, so thus far we've covered the concept of miniaturization of technologies, different ways of monitoring patients, trying to capture disease before it occurs. Talked a little bit about the baseline study, but at the heart of it as a clinical trialist, I think that we have to be a little bit careful between what is an observation, so a correlation. So if we have a lot of data capture that's coming in on the left-hand side of the slide, and we have a lot of data sources, so studies are getting bigger and bigger, they're covering large swaths of patients, how are we going to know what is a true signal, what is causative, as opposed to correlations? And we need the correlations to help us figure out what to study. But it's just a reminder, mostly to myself and others, to say when we see these non-randomized exposures and we see them associated with outcomes, we have to then go back and embed randomization. And so it circles back to Mort's comment about, should we be thinking about some of these cohorts that are ongoing and randomize people potentially to getting coronary calcium, or figuring out how to embed it so that you truly can try to come up with a something that you think is causative. And so we could experiment and think about, do any of these studies, these large studies, have the opportunity to get coronary calcium and randomize to different treatment strategies, and that may streamline things. And I think if we do that, then we ultimately will be making a difference on the population level, but also on the personal level. So it's a very high-level overview of where things are going, and I'll certainly happy to keep people posted as we roll things out. And we're always interested in your input as well. So thank you.
Okay, you want to have some comments before you leave?
No, unfortunately, I've got to go. I just wanted to point out what you asked me to. If you comment on is a true imaging strategy for atherosclerosis detection, which we came up with basically based on the idea that about 20 to 30% of patients with negative coronary calcium score or zero calcium score have carotid plaque. And 20 to 30% of those with normal carotid actually have coronary calcium greater than zero. So a practical strategy might be to begin with imaging one vascular bed first. If it is abnormal, you stop there and you identify something with atherosclerosis. That vascular bed is negative, go to the second vascular bed in the heart. And that way you will capture coronary and or carotid atherosclerosis and further de-risk a zero coronary calcium score, even lower risk. And that's really the idea based on the observations that we have.
Thanks. We're going to discuss that.
Think about it.
Can I ask the group one question? How interesting is it to get how much work has been done on serial coronary calcium? I hear us say 5 years, 10 years. What's the...
I've done a few of those.
Yeah, so I mean, what's the, if you were to, out of curiosity, I mean, if you were to do serial coronary calcium, what time interval would you do?
So in Mesa, we did it every 2.5 years for 4 imaging. So we have 10 years of data over 4 imaging time points, so really 5 imaging time points. We did some studies in my lab with about 3-year follow-up. So I'd say 2.5 to 3 years is probably a sweet spot to see if somebody's progressing, not progressing, or in those 2 general categories.
And these are treatment naive patients.
All comers. This is Mesa. These are observational studies. So these are both people treated and continuing treatment, and patients not being treated and continuing with no treatment.
So the issue, one major issue of this protocol would be if you have positive coronary artery calcium, you stop there and you don't assess this, then you randomize them to statin therapy and may have dilution of treatment effect for events that are mediated by here. So maybe a default strategy should be all comers should have no scan here, as well as do a carotid assessment too. In order to capture events.
Carotid.
Yeah, in order to capture it. I mean, this is all about.
But I'll tell you, if you review the literature on etiofemoral disease versus carotid disease, you will find that of those people who have femoral disease, about 50% will not have carotid disease. So if you were to look at one vascular bed, and you only have to do one vascular bed, I actually would do femoral.
It would be you.
Well, whichever way.
Wait a second. I think the most important defense that we're concerned about
Coronary.
The cerebral and
cerebrovascular and cardiac.
Yeah.
Because those events are also the biggest killers of those who prepare for vascular. For those two vascular events, carotid and coronary make more sense.
It's easier to acquire as well. I think you get some pushback from patients. There was a company we tried working with where you had to put sensors on the toes, and that proved to be a big deal in the United States because people didn't want to take their shoes and socks off and were embarrassed and all of this other thing. So I think getting to the femoral artery is going to pose even more
You're gonna
personal
miss-
decision.
You're gonna miss 14%
Yeah,
of
what-
events if you don't study the other vascular events. That's the study that I showed of the diabetics and the pulsars.
We're going to discuss this double testing towards the end. Pinky had a medical appointment, had to go. And poor guy was not in a position to get out of it. Okay, and stay with us. I'd like to conclude, add some comments on Jessica's presentation. So this study, the baseline study, has not been formalized or concluded in details yet.
It's still, yeah, it's
It's
still.
still being developed?
Yes.
Being developed. Is there a potential for collaboration with Google? Is there possibility to do coronary calcium in those subjects?
Well, there is, so as I said, it's being built out now, so that's why it's good to hear what the interests are of the group.
And
There
I
is-
would say that EHRs now, both Epic and Cerner, both include coronary calcium as defined endpoints or defined data points. So if you ever went to electronic medical record data capture as part of whatever you're doing, you would have coronary calcium scores if they were obtained in the patients as part of that.
The baseline protocol includes coronary calcium scanning in the cardiovascular cohort. I don't know if I'm not allowed to say it.
Is that right? That's the question.
Uh-oh.
It's being discussed.
Being discussed. So the
Being
question
discussed,
is,
so-
do you have a patient population that is too young or too old? or-
Yeah, I mean, so it's, no, nothing, I mean, all of this is being ironed out.
I don't think you'll making home.
No.
You'll be axed at the door.
Yeah,
Oh.
Google X.
No, so the idea is to actually get a full range of ages, so to get younger individuals, older individuals, and to get coronary calcium. Some of that's why I was raising it to the group, is what would be the right time interval around getting these studies and what would be most interesting.
Yeah, I think if you wanted to repeat calcium score in that context, I would wait 5 years to reassess risk rather than look for short-term progression. I think IMT is much better at progression. Calcium is much better at reassessing risk. So I would choose different time points for different tests.
So let me ask a reassessing question. The 0 to positive, I understand very well. The progression for people who are positive, my understanding was your calcium score can increase if you're better managing your risk factors and also getting worse in your risk factors, because essentially it's a marker of plaques which are healing. It could be your kind of vulnerable plaques which are stabilizing, or it could be development of more plaques. Is that
So that's true. So, and statins may increase calcification to some degree because of the density, making it more dense and more stable plaque. But rapid progression, however you define that, is always associated with 4 to 6 times more events, both in MESA and in other cohorts. Each cohort study was over 1,000 patients, the largest being MESA at 7,000. My other study being about 4,500. We have pretty large cohort studies to show that if you are rapidly progressing calcium, that's a bad thing. Short of that, it's not a great marker to say, is my statin working or not?
And that's really where we see
Yeah.
functional assessment.
Yeah, and I would never advocate now in today's environment, a serial study looking at a drug and saying, I want to see what the effect is on coronary calcium.